Lynn Redner, input from the Employees Association.
Thank you, Alice. Hi, everyone. This is Lynn Redner. I'm the president of Employees Association of Professionals. I just, I've been communicating with Alex and Lauren. We meet regularly to discuss things that have been happening and going on. And Alex asked if I would want to share with you how things are going with us, and I just wanted to take the opportunity to share in person with you guys how pleased we are. Our communication lines have really improved a lot, I feel. Going back to our negotiations that we had, a few years back, and moving forward, we're very grateful. Cal Forest has been very kind to us and very supportive of the staff. And we're super grateful for that. It stems all the way back to, shortly after negotiating, insurance costs went up, and we were, that cost was not passed on to us, and it came right after negotiations. That could have easily been something we would have had to deal with. When COVID hit, I feel like our support has been very tremendous from the organization. We have been supported with PPE, with testing, with time off, with support, with payment, and just recently had the addition of the talk space, which I think is really a wonderful thing to our community of employees, to be able to call in with no additional costs or screening to get help emotionally, or and I haven't used that venue myself, but I'm really excited that that's an option. Let's see, what else did I want to say? We're grateful that gain sharing came in during this really tough year. We didn't expect that, and we're grateful for that. I just wanted to share with you all that, we all have the same goal. We want happy employees. We want a safe, happy workplace and good lines of communication. And I think with that goal, from all of us having that in mind, I think we're achieving a lot right now. We can see that in our surveys and our gain sharing and our press gainy. So thank you. You all are at the foundation of that as well, and we appreciate your support, and just want to take the opportunity to thank you.
Well, we're really excited that you came to speak to us. We've always had the EAP, we've always had the Employees Association on our agenda, and for a while your past president came, and then things happened, and we haven't heard anything from the staff. And certainly you and the whole staff are so important to us as a board, because without you, we couldn't accomplish half the things, or even 90% of the things that we do. So thank you for doing that. But since we've got you, does our board have any questions for Lynn, who is the president? And you said of the EAP, so is it not a combined?
I think I could speak pretty freely on behalf of the EA, but they are kind of treated separately. We work together in a lot of the negotiations, but when it comes to, it does get separated out somewhat. But I have not heard anything negative from the EA side of things. I feel like, they are communicating well. So. Yeah.
Okay.
Yeah, Alice, I would echo your appreciation for having Lynn here. I think it's great to hear from the EAP.
Thank you.
It's always good to hear from the source, because certainly things can translate differently coming from other people. So we really appreciate you coming and talking. Whether it's good or bad or otherwise, the board really wants to know how our employees are. So thank you.
Thank you.
Alice, I'd like to add kudos to Alex McLennan and his department for their efforts, their creative efforts. If you've read Alex's report in detail, in building a culture based on a foundation of trust and our core values during these tough COVID times. So hats off to Alex and his department for their work.
I agree. I from anybody that I have been involved with that has either been off work for COVID or been affected by COVID, I've always gotten really positive feedback from the organization's handling of the communications. It's a scary time for everybody, and to be off work and not to really know when you're going to get released back to work. There's a lot of hoops to jump through. And I think the organization did a really good job, in a time where we haven't had this practice before. This was, we were on the fly with it. So I also appreciate the fact that throughout the year, we managed to pretty much get up and rolling. As in July, we were back to pretty much trying to do, work and service the community and keep that safe for everybody. And it's, a lot of hospitals were unable to do surgeries, let's say, or keep doing the business, the daily operations. And I think Tahoe Forest worked really hard to keep it a safe environment, but keep doing the business.
And Lynn, if I just want to say thank you myself, because I know that the board hears from us often, and we give our updates, and everything sounds like roses and strawberries, and I just really wanted them to hear from you, because I don't want I want the board to hear from you, because I know we've worked hard and you guys have worked hard too, and I thank you guys, because it is an effort to come to these meetings every 2 weeks, and we talk all the time, and sometimes it's times where we just get on the phone real quick and say, yep, we don't have any issues, but it's really important that we keep that communication line open, and I just appreciate your dedication, because I know you're not getting anything extra to do this. So thank you for what you do as well.
Thank you, Alex.
And also, just to let you know, Lynn, is that the Employees Association is on our agenda every month. So please feel free to come back. You can just let Martina, our clerk, know. You don't even have to let her know. You can just show up, and as soon as we ask for it, your input would be appreciated. So thanks again. Any other
Great.
comments from our audience or board? Okay. I have a legal question to ask our,
Sorry, is this public comment?
just a
I
minute,
missed-
please. Just a minute. Is David on the line?
Yes.
David, so Sarah was here for our closed session, not knowing that she couldn't speak then. We've passed the audience input, but she's here now. So can I go ahead and go back and let her speak?
Yes, you can. That's at the discretion of the chair.
Okay.
Is
So
she
Sarah,
speaking of agenda item or not?
no, it's a non-agenda item, she said.
Okay.
And then Sarah, 3 minutes.
Of course, definitely.
Okay.
Thank you for taking the time. I didn't realize I was running so late. I, of course, had trouble getting in on the Zoom. But thank you. My name is Sarah Green. I'm a Truckee community member, and I attended the master plan workshop last week. I think it's great that you guys are, making such a concerted effort to involve the community in this process. I think that's really important, and it's obviously a key component of any development project like this, especially one as big as your effort is. I am hoping to pass the word on to other people. I got the word out last week actually about the workshop, and I would love to spread the word as well going forward, but I've been told that there aren't any outreach materials currently available. And I think it's important, if not critical, to have some description of what this process is about. And the maps that were used in the workshop last week were really valuable. I don't know if you want to make those available, but some description that someone like me could pass on to someone saying, here's what the master plan's all about. And I know some of your upcoming meetings are tentative, but when those get pinned down, it'd be good to have something ready to go. So I just wanted to pass that word on, and when those materials are available, I would be more than happy to help spread the word about your effort. And I wish you luck, and thank you for taking the time to hear me this evening.
All right, thank you, Sarah.
Sure.
We have Safety First and Karen Buffone. Is Karen? I see her picture. She's muted.
Okay, sorry, I was
Oh, there it
muted
is.
again. So thank you, Director Wong. And this is Karen Buffone. I'm the CNO, and I'm here to do your safety first tonight. And what we're going to be talking about is the loosening of visitor restrictions and the safety involved in that. So as you know, the health and safety of our patients and their support people or family members are a top priority within the district. And we have really strived to keep both of our facilities clean and safe during this pandemic. And part of that included limiting visitors inside of the hospitals and the clinics. We've also been aware that during this pandemic, the absence of these support people and family members for our patients has been extremely difficult despite the technology that we have available. So as you all know, Zoom can become old, as well as using an iPad or an iPhone to be able to, or other brands of that technology to communicate. So on February 10th, the district began loosening our visitor restrictions. And our change and loosening of these restrictions has been consistent with both the CDC guidelines and the California Department of Public Health recommendations for visitors within healthcare systems. So I want you to be aware that the changes are subject to change based on COVID-19 and the pandemic situation and any direction that we would get from the federal, state, or local government. So what I'm talking about tonight is really the safety of letting people in, provided that we don't have an increase in COVID. So we have traced all of our employees for about 9 months now. So every day when employees come to work, they are asked a series of questions and before they begin work and put on their PPE. And with the loosening of visitor policy, it was essential that we had a way to screen the people that are actually coming into the hospital. So if you've been a patient or you've been in the lobby of the hospital, you know that we've had a security guard sitting out front, or even over in the MOB that does some screening prior to people entering the facility. But we felt that we really needed to have a better way of screening visitors and patients that are coming in to the hospital, as well as our clinics. So to decrease the number of resources that are necessary, I worked with Jake Dorst, who you know as our innovation officer. He's full of ideas, and he is that you laughing?
Well, it's something.
Yeah. Yeah, well, he's always got something. And so what he had was a kiosk that would be able to provide a screen for patients or visitors to answer the questions. And then you actually look into the screen and it takes a picture of you and sees that you're wearing a mask, and it also takes your temperature. And we now have the ability for our district to screen all visitors and patients coming in at a variety of different locations. So they're just being installed. The other thing that's very cool is about these kiosks is that it prints out a badge. So anybody that is actually within a clinic or within the hospital will be wearing this badge, which really kind of identifies the date and time that they entered the facility. In addition to that, the scanner actually holds the data for us, so that if we were ever asked by CDPH or somebody to go back and look at a particular situation, or we had a situation where we needed to go back, we have that information available to us. So in loosening our visitor policy, we've had great compliance, and look forward to this kiosk as being a safe and effective way of keeping our facilities free of COVID while providing support to our patients. So that is your safety first this evening. Any questions?
That is great, Karen. That is so unbelievably great. Have we allowed visitors in before these kiosks have been put in place?
Yes. Yes, we
So
have.
now
but-
patients can have visitors one at a time, or
Yeah,
how
we
is
have
that?
we have a whole list of regulations. If you're interested, you can find them on the TFHD website, but I can give you like just a brief synopsis. Like each visitor can have one person come in, and the visiting hours right now are from 1 o'clock in the afternoon till 6 o'clock in the evening. And the reason for that is so that we can really have some control on the number of people that are entering and exiting the facility. And we picked the 6 o'clock hour because we didn't want to get into a shift change situation within the hospital. So in the clinics, clinics are actually allowing one person to be able to go in if somebody needs assistance. Like a lot of times our elderly population need help getting to and from the doctor. So we will now have this kiosk available to screen everybody that's going in. If you ever want to take a look at it, it'll be it's at the front entrance of the hospital. And, you know, I'm super thankful to Jake for helping me find such an innovative way of being able to keep our patients and our entire community safe by screening them before entry.
So next time you're in the Safeway, they use the same company technology. It's called Turing for their employees. So you'll notice the employees at the Safeway all have like the daily sticker on their chest.
Does anybody have any other comments or questions for Karen?
Good job, Jake.
Yeah, thank you both.
That's why
Karen.
he's one of the top best in the country.
Karen makes me better than I am.
Yeah. Remember that, Karen.
I've got it.
Okay.
We all heard that.
Mhm.
Well, thanks. And I think having visitors, and especially those that are being discharged, will have that support person to hear the discharge instructions and some of the issues that we've had sending patients home with information. So I think that's a great move through this pandemic. Item 13, we have our February 2021 Employee of the Month, and Alex McClellan, our Chief HR Officer, will give that.
Great, thank you. I'm honored tonight to announce that Fabiola Herrera Perez is our February 21 Employee of the Month. Give it up for Fabiola. Fabiola has been with the district since October 2018, and here's some of the things that her colleagues say about her. Fabi is an extremely hard worker and does so every day with a smile on her face and a pep in her step. She is thorough, efficient, kind, patient, and a joy to be around the office. I can always count on her to help pick up any slack, and she does all front and back office duties right the first time, every time. She has also been covering the respiratory illness clinic, and I've heard from many people how timely, wonderful, and helpful she is there as well. She absolutely deserves this recognition, as her work ethic truly touches on all of our values. We love and appreciate you, Fabi. You are an amazing asset to our team.
Yay.
Yay, Fabiola. She really is a remarkable employee.
So congratulations to Fabiola. And then our 13.2 acknowledgement, we've got Ted Owens, who's going to present Marie Martins, and who both of them did the Spanish-speaking town hall on COVID vaccines, correct?
Correct. Thank you, Chair Wong and directors. It's my pleasure really to bring Maria hopefully in. She's long distance, so we'll see if that works. And Lizzie Hennessy also from Wellness. We worked together to put together a Spanish town hall for our Spanish speaking community I'll let them share a little bit of the partnerships that we built in order to get folks to participate. And we're going to show you a little clip of it, and we think you'll enjoy it. We'll see our very own Shawnee Cole speaking entirely in Spanish, Dr. Samuelson, and also Sam Smith. So with that, Maria, if you're there, I'll turn it over to you. Otherwise, Lizzie, if you could jump in.
I'm happy to jump in. This was a wonderful partnership between wellness and the providers in the health system and Sierra Community House. So thank you to Dr. Cole, Dr. Samuelson, and Sam Smith, physician's assistant. And then our moderator was Anibal Cordoba Sosa, who's been with Sierra Community House for a number of years. We knew there was a need for additional information with our Spanish-speaking community, and this was one avenue that we chose to take to really have more of a relationship and an active outreach with this specific community. I don't know if you want to show the video now, Ted, and I'm happy to answer questions about where we are at the moment with vaccine clinic appointments for this population.
Let's show it now. Martina looks like she's ready, and let's hope there might be a little lag here, but we'll
Our
watch
Hispanic community has been disproportionately impacted by COVID-19. In response to this inequity, Tahoe Forest partnered with Sierra Community House to offer a Spanish language town hall.
Buenas noches y mucho gusto a todos. Gracias por venir. El vacuna no es el virus, es una proteína muy similar que tiene el virus, pero usted no va a tener COVID de esta vacuna, es imposible.
Gracias para su tiempo en esta noche. Yo pienso es muy importante para mi comunidad comprender y estar seguro con esa vacuna, porque COVID es una infección de malo. Entonces es muy importante sobre mucha información sobre la vacuna.
No recomendamos dejar usar la mascarilla porque la vacuna pensamos que es 95% efectivo. Entonces todavía hay riesgo de que pasar el COVID es mucho mejor que no recibir la vacuna, pero no es 100%. Entonces para bajar el riesgo del COVID, muy importante seguir usando la mascarilla.
Virtual town hall format is a strong tool for advocacy, communication, and education. Our goals from this talk were to increase vaccination rates and create a model to support future Spanish language outreach while addressing health equity.
Okay, can you hear me?
Yes.
I hope you enjoyed that. It was a lot of fun to watch the whole thing. Lizzie can add a little bit more if you like, or entertain questions of the board that you may have.
Whichever, I'll say that's just a small snapshot.
You got a question?
Go ahead. The full talk was a little over an hour, but we squeezed it into a minute and a half there.
How we're in attendance?
¿Cuántas personas pueden ver a esta?
¿Qué dice?
¿Cuántas personas miran esta?
Como 45. There are about 45 people there.
Okay. Very good, Dale.
¿Hay más preguntas en español?
And Lizzie, do you have any feedback on how many of them have appointments now?
No, not specifically because of the eligibility limitations and it being 65 and up. A lot of people on the call were younger and maybe representing their parents, but I do know there was one specifically that was linked with a promotora and linked up to get an appointment. But apart from that one, I've not heard personal stories.
Okay.
Director King had his hand up.
So what's the follow-up now?
We don't have a specific outreach model follow-up. We're hoping to use the town hall format in the future. But I do know as an action from that, what is happening right now is they're piloting, setting aside a specific number of appointments specifically for these vulnerable populations. So right now there are 50 spots that have been set aside for Tuesday, and our promotors are actively reaching out to these vulnerable populations. So these are people who are in the eligible tier, but they do not have internet. They may have a phone, but it's a flip phone. They don't have email, language is a barrier. So what was happening is our promotors were already helping them on the phone. They would walk them through the process, but it would take around 15 minutes. So in the time that before it closed, and all the appointments were full, our promoters were able to only schedule 4 people. So just the multiple barriers that this population has, hopefully this pilot works out well. And then if they're not full, I think within a couple of days of Tuesday, they'll open it up to the broader population. But I know that one of our promoters specifically is planning on doing place-based outreach. So she will go to the senior apartment. She's going to go to Donna Creek Mobile Home Park, and she's planning on doing direct outreach that way.
Great.
I would like to add one thing also for the board. We have posted the entire educational video on our website. We have also pushed it out through the Chamber of Commerce to their entire membership, as well as the Contractors Association as well.
Any other comments, Mary?
Yeah, I have a question. It's not necessarily, it doesn't necessarily relate to the Spanish-speaking community, but rather to a transient community that we may have coming through, or the community there. And it has to do with the Johnson & Johnson vaccine once that becomes available. I'm wondering if there's any plan afoot to use the one-shot nature of the Johnson & Johnson vaccine to reach out to the transient community, whether it's through the warming center or what have you. But this is a population that you can't necessarily count on coming back in 3 weeks or 4 weeks or what have you. And I'm wondering if Johnson & Johnson will free us up to be able to have an impact in that regard.
This is Judy. I can try to respond to that. So again, we never really, just to begin with, we really don't know what vaccines we're going to get. But I will say that the Nevada County Public Health has been very active in working on the east side of the county also, just regarding, those individuals that are more vulnerable, and they've also then talked about the transient. So we haven't got into that much detail, but I know that they have been active in assuring that people get vaccinated. And most certainly, I think if we do get the single dose, that's an opportunity.
Thank you.
Any other questions about the Spanish-speaking town hall on the vaccines? Well, thank you.
Any more, I know I asked about follow-up, any more meetings planned, or, so we can kind of keep this thing going?
I think that's a wonderful idea.
It is, and Lizzie and Marie and I are meeting almost weekly now, schedules allowing, to explore that. This is a moment in time to discuss the vaccine and COVID. And as things change, I think we have other opportunities certainly to take advantage of.
Also, I just want to mention that Nevada County actually hired an employee that sits on the east side of the county to reach out to community members, especially the Spanish community. So they've been involved in that, and then also are able then to give our team information on those individuals that want to be vaccinated, and we are still getting that information. So they actually are active, and they go door to door also. So I know a lot of people don't realize what the county's doing, but they have been Nevada County has been very active in reaching out both on the east side and the west side for this vulnerable population.
That's great.
And then can I ask also, it sort of ties into it, but have you identified the leaders in the Spanish community? I mean, there are some members who are much more embracing, the general population and all the things that are going on. And I wondered if, like, some of the business people that are Hispanic, have you reached out to them to see if they can also help spread the word about the vaccine and the availability for appointments?
Pretty much our marketing plan, it was a really short turnaround, and we rely heavily on our community partners. So that's the Community Collaborative, which, as you probably know, is 45 local social service organizations, including the school district and Sierra Community House. Those were our main avenues. We did not visit businesses directly, but we really rely on the promotor network Sierra Community House also has multiple promotoras throughout the region, not just in Truckee and North Lake as well. We relied heavily on the school district. We went through ELAC and their marketing director, Kelly Toomey, and their translation services, their community liaisons, but not directly business owners. I think that's a great idea, something to think about moving forward if we didn't reach them in this short turnaround we had for this event.
Mhm.
And I do want to say, I think at some point we will have targeted outreach, or will need to have targeted outreach for vaccine hesitancy, especially for this population.
Well, thank you
But
so much.
Alice, I think some of our campaign is going through our medical staff. The fact that we were able to get this particular Spanish-speaking education session up on our website and referring those patients back to that, to be watching this to help with that vaccine hesitancy was part of the point of why we put it up on our website. I also do think that we had a lot of younger patients listening that evening, but I think that they were the representative for their grandparents or whomever. So I do know that right after that, we did get an uptick in some people that I think were related to those that listened in on it and said, yes, you know, mi abuela necesita su vacuna.
Yeah, so many of them live in multi-generational housing, so that, yeah, well, I can see that happening, and hopefully they're able to, you know, go through the internet or the web and get their grandparents, their parents, or whoever vaccinated, or at least appointments.
I would hope that this would somehow our learnings from all of this would become the basis for ongoing outreach in the future, rather than, you know, this COVID episode, but rather again to continue with our learnings and our teachings.
Okay. Any further
That's
comments?
why we're meeting every week now. So thank you, Director Brown.
All right. Then we'll move on to item 14, the Medical Staff Executive Committee report.
Thank you. Jonathan Lane again. So we, Dorothy should have included in your packet, we have annual plans that need to be reviewed. There was many of them this month, I think 20 of them. And so minimal changes in most of the annual plans that we went through, such as quality assessment, utilization review, risk management, et cetera, on those. And then the next set were some things that came out of the trauma committee, and trauma committee has obviously been very active as we are putting in place all of the protocols and things we need to become a level 3 trauma center. Most of that is done. And so we had 4 more there, such as if the ED provider is pulled away, what do we do? Trauma activation algorithm, practice guidelines, and evaluation of an adult with traumatic brain injury. And then we had changes in the one for number 19 for IV therapy, and it was how there were some mild modifications. We changed the tubing on IV therapy for patients at least every 72 hours, and depending on what's going on, every 24 hours, and even sometimes on propofol, for instance, every 12 hours. And the main real change on this was to try to minimize the use of heparin, which is a blood thinner, and just use saline instead. And so that's the main change that came about in this protocol. And then the very last one is on implantable loop recorders. And those are, it's somewhat like a pacemaker that's implanted in the patient under the skin. It's not a pacemaker, but what it does is it records electrical activity and allows remote monitoring. So we can tell if patients are in abnormal heart rhythms or potentially in something dangerous, allows for regular monitoring. And then this just explains who does the monitoring, and they're talking about a registered nurse or a trained monitor tech, and what the procedure is. And I think this was written by Dr. Skolnick. Any questions on these? And MEC has approved all of these.
Yeah, this is Art. I've got a question on the annual plans. Are these plans required or are this just best practice? I mean, are these things we have to do?
Shawnee, can you
Yes.
chime in on that? I know that I think it's both, but I think some of them are required, but I'm not positive I can answer that.
Yeah, we do have to review them annually.
I can answer. Those are annually required approvals, regulatory required approvals.
Okay.
Director King.
So I saw that we had all of these last February too. So that's why I was wondering.
And you'll see it again next year and the year
I'm
after.
sure we will.
And oftentimes, Art, there's just minor changes that are made in some of those plans because they're so comprehensive to begin with.
Yeah.
I know that the quality committee went through the QA/PI plan, and I think there were like 2 or 3 changes. One had to do with COVID, another had to do with, I can't remember it, but it was a minor change considering the plan is so
It was our
comprehensive to
survey.
Our surveys, yeah.
It was we had our HVAP survey in 2020, and this year we have our CDPH survey for Tower Forest Hospital. Those were the 2 changes.
Okay.
So I think that's all I have unless anyone else has any questions.
Okay. If there are no further questions, can I have a motion to approve the medical staff consent?
Chair Wong, do you
agenda?
want to remind the audience if they did want to make public comment that there's a raise hand feature under the reactions button?
Okay. So did everybody hear that wanted to make a comment? There's a wave hand that you can hit under the reactions. There's also smiley faces and hearts. Any emoji you want. Okay, so if there's no comments, can I have a motion?
Thanks, Alex. I so move. This is Art.
And a second,
second.
please.
Michael, second.
Okay, so it's moved by Art King and seconded by Michael McGarry to approve the medical staff consent agenda. Martina, can you do the roll call?
Director McGarry,
All right.
Director Shamblin, Dale,
He's on mute.
Aye.
Director King,
Aye.
Director Brown.
Aye.
And Director Wong.
Aye. So the medical staff agenda calendar is approved. Thank you again, Dr. Lane. And Dorothy. Item 15 is the consent calendar, and these are usually reports. Nothing that's usually controversial, but there's always the opportunity for someone to pull pull any of the items under consent calendar. Are there any of them that you would like to pull? Anybody?
I just have a quick comment. Can I make a comment?
You can make a comment.
Yeah, on the quality assurance performance improvement plan, I did have a couple of questions that I sent to Janet, and I asked her maybe next year we could get a little summary of changes so we don't have to read through the whole plan again to look for the changes. So she said she would do that next year.
Yeah. And the one thing that I know the medical staff did is they colored what the changes were.
Yeah.
So that we
would
were
work
able
too.
to see that, especially on the policies. So Janet, is that a possibility?
Absolutely, and I can't raise my hand because I'm on my cell phone, but yeah.
Okay. Well, you can raise your hand, but we can't see it.
Yeah.
There you go.
Can I have
And you're
a
right, I just
motion?
raised my hand.
Okay. Can I have are there any further discussion? I keep hearing voices.
I'll move approval of the consent calendar.
Okay.
Dale?
So is that, can I have a second, please?
This is Mary, I'll second.
Okay, so it's been moved by Dale Shamlin, second by Mary Brown to approve the consent calendar as presented.
Director
Martina?
McGarry,
Aye.
Director Shamblin,
Aye.
Director King,
Aye.
Director Brown,
Aye.
Director Wong.
Aye. So the consent calendar has been approved. We'll move on to 16, items for board discussion. And our first one is the hospital pricing transparency rule. And Crystal Betts, our Chief Financial Officer, is going to give us the highlights of this. Crystal?
I'm going to try.
Okay.
So, Martina, are you going to display the presentation or should I go ahead and do that?
I made you co-host, so you should be able to share.
Okay. Let me pull things up here.
You want me to come back, Crystal?
Not yet.
There you go.
He saved me earlier, so thank God for Jake. That's all I can say. Okay, so first of all, I did want to let the board members know that I was able to reach out to CHA and ask if it was okay to utilize a presentation that they had put together for hospitals. And they said, absolutely. The only thing they asked for is credit for the presentation, which you can see right here, California Hospital Association, and that the speakers that put it together got credit as well. So Katrina and Alicia did a wonderful job on this presentation, so I am robbing from them a little bit, but it's well worth it. I'm going to kind of scroll down here. So pricing transparency has actually been around for a while now for hospitals. Back in 2015, under the Affordable Care Act, it was required for hospitals to post their charge master for the public to be able to access. It was pretty loose. It didn't say what format or how or anything like that, but hospitals had to make it available for the public or make it in a way where the public could request seeing what the charges were. So it's fairly loose back in 2015. In 2019, they tightened that up a little bit and said that you had to have it online in a machine readable format. So they did tighten it up, and that every year on January 1, you have to update it with your most recent charge master. For those of you that aren't familiar with what a charge master is, it's basically a listing of every single item that a hospital could possibly charge for. And so it is thousands of lines long, thousands. And it contains descriptions and codes and prices, and it's a pretty meaty beast. And so what basically people are finding is that that's great that hospitals had to post this for them to access, but most of the time the public has no idea what they're looking at because it's just a giant list of gobbledygook to any person that doesn't work in healthcare. So it really hasn't been very beneficial. So a new requirement came out, and that's the one we're going to talk about tonight, that was required to be put in place on January 1st of 2021. Now that's an extended go live date. It was earlier, but this new law was being challenged by hospitals, by payers, by several individuals in the healthcare industry. So, but it has stood, and the requirement was required to be in place on January 1st of 2021. So let's look at the January 2021 requirement. It is requiring two different disclosures for hospitals. And actually it's more than hospitals, and we'll get to that in a minute. The first disclosure is it's a machine readable file of standard charges. So they no longer are referencing what we call the charge master. They're referencing now what they're defining as standard charges. And it's in a machine readable file format, which means it has to be a CBS, or I think it's, Jay, correct me if I'm wrong, XMPL or something like that. And there's another one that you can do as well. We chose to do the CSV file, so that is the format our machine readable one is in.
That just means comma separated values. So in between every value, there's a comma. So the machine can say, okay, that's a column, that's a new column, that's a new column, when it sees a
Yep.
column.
Mr. IT guy.
If that helps,
So,
I don't know if it doesn't.
so these standard charges now have to show basically what our gross charges are, which is what we refer to as our charge master. It also has to include what we've negotiated with specific payers for every item and service that the hospital offers. So it discloses quite a bit. And this was fairly controversial because of the payer-specific negotiated rates. Most contracts require that to be confidential. So it was very interesting that this came out requiring us to disclose it when potentially our contracts could say we can't. So that was a huge area of dispute.
Crystal, who pays the charge master rate, if anyone?
I'm sorry, could you repeat that, Dale?
Who pays the charge master rate, if anyone?
Actually, there are out-of-network insurance companies that would change or pay 100% of charges. There are some commercial contracts where we could potentially have 100% of charges. Technically, self-pay, if they don't pay a time of service, could be 100% of charges. There are some worker comp circumstances where, because we're a critical access hospital, they would have to pay 100% of charges. So there are some circumstances where that does apply.
Okay.
Okay. So the second disclosure is what they're calling a consumer-friendly disclosure, so the public can understand it, of what is defined as shoppable services. And we had two options for this. We could either do an estimator tool on our internet, where a person from the public could go put information in on one of the common shoppable services that are defined, or we could do some other kind of listing. So they left it kind of up to us how we wanted to do it. The note at the bottom, California for a long time has required us to send our charge master and our 25 most common procedure charges to the Office of Statewide Health Planning and Development. We call them OSHPD. So this ruling does not alleviate us from having to still comply with the California transparency rules. We have to do both now. So I just wanted to point that out. So the rule applies to basically anything that shows up on the hospital license. So if it's on our hospital license, that charge has to be disclosed. So if it's not on the hospital license, then technically we don't have to disclose it, nor do we have to disclose for providers that might provide services at our hospital that we don't bill for. So like in our circumstance, the anesthesiologist or the emergency room physicians, we don't have to disclose any of that pricing because we don't bill for that. So if it's not on the hospital license, technically we do not have to disclose it as part of this ruling. You will see here that ambulatory surgery centers and other non-hospital sites, community health clinics, FQHCs, they do not have to disclose this information, but critical access hospitals do, psych facilities, full community hospitals, it applies to them. All right, so let's get into the first disclosure. We started talking about standard charges. So the first disclosure requires us to disclose our gross charge, in essence, basically our charge master. It also requires us to show, they call it the de-identified minimum and maximum. So we don't have to say who the payer is, but we do have to say who pays us the best, maximum, and who pays us basically the worst, the minimum. And these are payers that we had to negotiate with. So we don't negotiate with Medicare, we don't negotiate with Medi-Cal, so we don't have to disclose that in here. But anybody we negotiate with, we have to disclose what the maximum we get paid and the minimum we get paid for every item in our charge master. We also have to disclose by payer what our actual negotiated charge is. So we look at our commercial payers that we negotiated with, like Cigna, Aetna, Anthem Blue Cross, and we have to disclose what we negotiated to be paid for each of the charges in our charge master. And then the last piece is what our discounted cash price is. So if we actually took our charge master and on a routine basis reduced our charge for cash payment, we would have to disclose that cash price. This does not mean a prompt pay discount for paying at time of service, which is how we're currently set up. The only thing we have discounted cash pricing on is sometimes like our community labs, where our community members can show up and pay cash and have certain labs done at a reduced price. That would go into this category. I already kind of covered this. Third-party payer really means whoever we've negotiated with. So there was a lot of discussion around that. And these are the items and services they were talking about for standard charges. It has to be supplies, room and board, kind of the whole works. So everything's basically included in that definition. Here's the machine readable requirements. It does require us to put all the codes in. So if there's a CPT code, a HCPCS code, a DRG, an NDC, those all have to be within the file as well. Here's a kind of a quick example of it. I'm going to show you our actual website as we get through this a little bit. One of the things that people brought up is this is all fine and great to have this machine readable file, but who's actually going to use it? And the bottom line is probably not the patients. It's probably going to be other hospitals. It's probably going to be other payers, commercial plans. It's probably going to be attorneys. It's not going to be the patients. So it's kind of ironic they have us jumping through all these hoops when, honestly, I don't think the patients are really going to use it. So the second disclosure requirement is the shoppable services, which we'll get to. And you can either do the internet-based estimator tool or some other listing that's consumer-friendly to show what the 300 shoppable services are. And this has been defined for us. So CMS has defined 70 specific shoppable services that they want hospitals to disclose. And then we get to pick the other 230. If we happen to not perform one of these 70, we have to state that we don't do it and replace it with one that we do. So no matter what, we have to have at least 300 shoppable services. And CMS does publicly post what those 70 are. We can take a peek at that in a little while here. I can show you if you're curious. But they should be kind of those common things that most of the patient population access. In this shoppable service, we do have to define it by location. So if you have imaging and you have imaging in your inpatient hospital and you have it in an outpatient setting and those are different prices, you have to disclose the price by location as well. So it's got to be location specific. And for each of these shoppable services, we have to disclose the same thing that was on that machine readable file. So we have to say what our gross charge is, what the minimum is, what the maximum is, what the cash price is, what the payer specific price is, negotiated rate is. So we still have to disclose all those same elements, but for each of these 300 items. They were very, very clear that the language that we had to use for these is consumer friendly. And not only do we have to provide it for the patient to view, it also has to come in the same comprehensive machine readable file. So not only do we have to make it user friendly, but we also have to post a CSV file too. And the other thing this requires us to do is kind of show the bundled charge. So you'll see in this example, a colonoscopy, if we have to show kind of all the charges related to that, not just a single code. So we have to take what the supplies were, what the OR time was, and we have to put that all together and disclose every single charge that makes up a colonoscopy. So it's not just one line item like an office visit. You can see for vaginal delivery, it can be several pieces. And if we don't bill for it, we have to disclose that. So that's the other piece of the shoppable. Let's see. So how is this all going to be enforced? Well, they plan to do audits. They plan to do it through investigation of complaints. For those that are not compliant with this rule, which there are hospitals out there saying they feel like there is a greater risk of being sued by a health plan for disclosing their contract rates than just sucking it up and being fined $300 a day for not being compliant. So there are some facilities out there defying this rule and just taking the risk of being fined or partially complying without, doing everything but disclosing the payer rates, et cetera. So there is a lot of controversy out there about this ruling. So I'm going to check to see if you guys have any questions. If not, I'd love to take you to our actual website and show you how we've put this in play at Tahoe Forest.
Yeah, I do have a question if I'm, Alice?
No, go ahead, Dale, I'll follow.
Okay, so Crystal, the colonoscopy, for instance, you have a physician service, you have a hospital charge, you have an anesthesia charge. The anesthesia, we're not billing for the anesthesia though, right? The anesthesia company bills, and they could be anywhere, could they not?
Yes, but we are not responsible for disclosing what their charge is. We are responsible for disclosing that we do not bill for that service, that it could be billed separately.
Okay, so for an individual, let's take something that's a little more pricey. Somebody needs a knee or a hip replacement, and they go to Barton and they get the physician charge, they get the charge for all the replacement parts, and they get the surgery charge, but they don't know what the anesthesia charge is going to be. How do you make an informed decision when you don't have all the pieces?
Well, that's a great question for this wonderful rule that they put into place, because it still doesn't solve the problem.
Yeah.
Now, on our website, we do disclose all this. We make it very clear that there are still some things the hospital does not bill for that is not included in these estimates or price estimators. And remember, right now the tool is limited to at least 300 services. I think ours is more like 400 that we've chosen to do. But again, it's not everything under the sun that a person might have done. It's only those common procedures. So, but all of that's disclosed, and I'd be happy to show you a few examples of that.
Great, go ahead. Thank you. I'm sorry.
So Crystal, when we pick one of these options to use to put our charges in, that one that's the estimator tool or the other one, is the template already there and we just fill in the information from our facility? You don't have to build the whole program.
So we chose to partner with a vendor named Para, and we had already been working with Para for quite a while. And so they had a lot of our charge information and contract information already. So it was pretty darn quick for us to become 100% compliant with this rule with our partnership with Para. And so when you actually go on our website to do this, it links you over to Para, where you are accessing our information. And the other thing that you have in here when you go to the Estimator tool is you have the option to actually enter your actual insurance information. And it'll pull up what your eligibility is, what your responsibility is, so it'll tell you what your plan is. You have a $500 deductible. You've paid $190 already towards your $500 deductible. It brings up your eligibility, and we'll take your information and apply it to the charge you've selected, and we'll say, based upon what your insurance company has on you right now, your out-of-pocket cost, not just what the charge is, but your out-of-pocket cost is $190 or whatever it might be. So you can choose to put your personal information in if you want to, or you can skip that and just get kind of generic information. And I thought about using my own information, but my date of birth and all that stuff would be live on our board meeting, so I don't think I'll do that, but I'll show you kind of what your options are.
Okay, thank you.
Any other
Any
questions?
questions before she moves on? Okay, Crystal, show us.
All right. Okay, so what we're going to do is we're going to go to our usual tfhd.com. You guys can see this okay? Okay, we're going to go to patient resources, and down here you'll see price information. And so right now it's taking you over to the PARA website. You can see PARA up here. And one of the first things that you'll see here is here's our standard charges. So this is what we're doing to be compliant with the first disclosure of the machine readable file. And you can click right here and it'll download. And it's about 54 megabytes. It's a huge file, and it takes probably, it took me almost a minute and a half to download the whole thing. And I'm going to show you real quick here. So this is us being compliant with disclosing the standard charges. You'll see that here's the plan name. So this one happens to be ADMAR. We have a procedure code, and this looks like it's an error, but there's actually information in it. Remember, this is the machine readable file that's converted to Excel for you to see. You have the procedure description. You have the unit price. This is our charge. You have the revenue code. If it has a CPT code or a HCPCS code, it's here. The description, the NDC code if it exists. If it has to be converted because it's a pharmaceutical charge, there's one, the conversion factors here. If you were to pay cash, it's here. Here's the minimum we negotiated, the maximum we negotiated, and then it starts going by area: inpatient, outpatient, ambulatory surgery, emergency observation. If there's a pro fee, it lands in this column. And so for every charge in the charge master by plan, we disclose this. This thing is huge. So this is just ADMAR multi-plan that I'm scrolling through. So this is for every single plan that we have. This file is huge. So my point being is we are compliant with the first disclosure requirement of the standard charge. So let's go back to our website here. Okay, so this right here, we're also required to show a list of our charges, same disclosure that I just showed you, but for every DRG or every diagnosis related group. So these are inpatient charges. So this is the same Excel file with all that same information disclosed by payer, but by DRG. So we're compliant with that too. Then we have the shoppable services one, which is at least the 300 services. The CSV file that we're required to have is right here, and it'll drop into Excel and you can view it. But the one we like our patients to use is this price estimator right here. So it says calculate your out-of-pocket costs. This takes you to kind of our disclosure that this is an estimate. It may not include some of this information, and you still need to understand your insurance plan. It's an estimate, it's not guaranteed. It's not a guarantee of your insurance coverage. I mean, we've tried to be as disclosing as much as we possibly can that this is an estimate. So that's super critical. So if you scroll down, we give you the option again to download all those CSV files if you want to. But basically you're saying, okay, I've read all this, I understand it's an estimate, let's move on. So now you can pick your service category. And so I'm gonna pick lab. And I'm gonna say, okay, what options do I have for lab? So it gives me this whole list. You can see it has codes associated with it. It could be the HCPCS, the CPT, the ICD-10, But this is the code associated with the provider ordering the lab work. And so I'm very familiar with this one, the TSH test. So I'm going to pick it. And I'm going to say, let me view that selected service. So it pops up and says, okay, you've picked the TSH test. For this test, you're going to get charged for the venipuncture, and here's the actual lab test. The total charge is $284. Now you can say, oh, I want to select insurance to see now what happens. And I'm commercial. And this is where it lets you put in your information if you want to get to your specific plan. But if you don't want to do that, you can continue without checking your eligibility. And then you can play. You can say, oh, well, my insurance plan is Blue Cross, and my yearly deductible is $500. I know I've already got $200 towards it. I always have a $30 copay. I know I have a 20% coinsurance. My out-of-pocket max is maybe $6,000, and I've already got $200 towards it. So you can put in information if you don't want to put in your actual, member ID and all that kind of stuff. And so once you do that, you can say, okay, I want to view my estimate. Now it tells you, okay, hey, we're looking at Blue Cross of California. Here's all the information you put in. Here's that charge again, $284. Here's the minimum negotiated charge. So the minimum we will get paid for this is $243. The maximum we will get paid for this per our payer contracts is $275. Here's the breakdown by plan. You can see, let's see, Blue Shield would actually have paid us $269, where Blue Cross was $243. And then it'll come down here and say, okay, based upon what you told us, you're going to be subject to paying the full $243 because you haven't met your deductible yet, basically. And then it says it's possible you can pay by cash, check, whatever. Has all these disclosures. If you want more information, you can call our financial counselors or email them, and it gives you all this information. And so you're like, okay, cool. I'm going to proceed to the out-of-pocket costs, and I'm going to do this again if you didn't have this right. And you can go back to viewing the estimate. You can say, okay, I'm done, but I want to put my own information in so I can see how this really works. Or maybe you just, you want to go back and select another service. So this is how our patients can interact with this tool to get estimates without having to call financial customer service or one of our financial counselors. For some simple ones like lab tests, I could see this being quite helpful. But, if we start getting into like inpatient services, we can get into OB. Oh, I'm going to have a cesarean with major complications. It just can start going to things that we don't necessarily have charges posted for. But eventually what we'd like to do is be able to use this tool 100%. And actually for the ones we have posted here, our own internal staff are using the same estimator tool if a patient was to call in. So we're giving consistent estimates whether a patient does it on their own or they call us, if it's one of the 400 that we've disclosed as part of the transparency requirements. So pretty slick, I thought, and we are 100% compliant with the transparency rule. We're trying to gather data right now to see how many members of the public are actually going to the site and utilizing it. We're only almost 2 months in, so give me a quarter and we'll hopefully have some statistics for you and see if this is actually being utilized. So that's my education session for you guys.
Wow.
Question for you, Crystal, if I may.
Sure.
You're muted, Chair Wong.
Oh, Alice is trying to talk.
Yeah. Oh.
The baby was crying, so I had to mute myself.
Oh.
But I thought it was a great presentation, and I say that you'll probably have an uptick of people using it, because as a board member, we're going to go on and kind of play with it to see what's there for sure. Are there any other comments from our board?
Yeah, Crystal, let's say, for instance, your primary care physician says, you know, you've had an inflamed appendix on several occasions. You really need to get it taken out. How do you get all those DPT codes for that surgery that's coming up so that you can enter them and know with some assurance that you've included everything that you're going to need when you have that surgery?
Well, you won't. What you should be able to do is go to an appendectomy code. And that, let me see if I can.
So it would be bundled?
Yes. So I was trying to see if I could find a bundled one for, oh, I know what I'll do. If you guys can bear with me for just a second. Let's show you an example here.
I see Harry smiling. He's wondering, why did Dale ask this question? Because my next question would be, why wouldn't I just pick up the phone and call the financial services department and say, hey, guess what? This is way too complex for me. I want to compare it with Barton's cost for this same surgery so I could figure out what my total out-of-pocket cost is going to be. Can your department walk me through and give me a number? And then I call Barton and ask for their department, and they say they don't have one. So then where are we?
Well, so we should be able to provide, when we did this work, we used our actual information from claims processed in Epic for these procedures. And so based upon that actual information, we could see what was most commonly bundled together when somebody had an appendectomy. And so we are able in our listing to see those revenue codes and the charges associated with it that are making up that total charge. And we should be able to absolutely share that with the patient. Now, you know, do I want to make the phone call down to Barton and get Barton's prices for them too, so they can decide whether they want to come to Tile Forest or Barton? Not so much, but at least they would have the codes where they could call Barton and ask the question if they really wanted to shop. So,
okay. Well, as you say, I wonder how many people are going to go through this anguish.
Well, at least it sounds like we're using this internally, so maybe that's one benefit of it.
There was hesitation by the staff that they were worried that if they were providing an estimate, it would be different than the estimate that would come out of this tool. And so we spent some time with all the staff that would actually be quoting prices to have them use this tool. And what they found is, you know, for the most part, this tool is pretty darn accurate for an estimate. Now, please remember, this is still an estimate. Things happen that we can't predict. But it's been pretty darn good with getting us in some pretty decent ranges to provide estimates. And the staff are feeling comfortable using this tool for the information we have in it to give those estimates to our patients. So they were pretty leery. They thought, you know, they would give a price and then a patient would go online and use this tool and get a different price. And then they would say, what the heck are you doing? I got two different prices for the same thing. We didn't want to create that kind of confusion.
Yeah.
Okay. Well.
Okay, any other comments or questions for Crystal?
Just real quick, I did go on earlier in the week and try it just to see if it works, and it works just like we saw. So it is actually a real thing.
It's a real thing.
Yeah.
right, well, we look forward to getting less complaints about estimates now with this new tool.
Well, I'm going to go and disclose, it's still going to be a challenge for the emergency room, period. Because that one is just super, super hard. But some of this other stuff we can dial in pretty good.
Okay. All right, we'll move on to 16.2, the COVID-19 update. And we've got Harry Weiss and Judy Newland are going to talk.
Yeah, good evening, Chair and members of the board. You can see that our health system is still very busy on many topics based on the variety of topics covered tonight. But just speaking about COVID-19, we're probably at least 11 months in this pandemic so far. I'm really proud of our entire team, their courage and their focus on our patients 24/7. I think they've really been amazing. And I think the lives that they've saved and the innovations they've done has really been amazing. And I can't overstate that. Judy offered early on to kind of be our leader point person. And I think all of our team really appreciates the nearly 7 days a week work that she's done. And just very briefly, you know, we've continued our partnering with our various counties and then other stakeholders like the school district. We did the largest number of vaccines on any given day that anybody's done in our wide region 3 weeks ago for our local school district. And tomorrow is part B of that very large effort as well. And that just shows how much we care and we stay in touch and we partner. We're really pleased with the huge downtrends, whether it's the infection rate that we're seeing on the lab tests or just the inpatient census. The big thing that we're really watching, and I think over the next 2 to 5, maybe 6 weeks, we're going to learn a lot, and hopefully we'll see a lot of positive growth in terms of Blue Shield's role to be kind of a statewide administrator of COVID-19. Our 2 counties have advised them that they really need to be talking to us for the eastern side of the Sierras services. We still have a huge need to provide services to over 65, under 65. And so we have a lot to learn about Blue Shield's role and when and if we're going to have a very large public health role beyond what we've been doing to date. So again, I'll turn it over to Judy and kind of share what else is going on.
Thank you, Harry. Thank you, board. I just wanted to mention last week we saw, I think we're down to about a 3% positivity rate. So a number of people that have tested versus positive. So that's really good news for our region. I would like to share with you, we had a 0% positive rate for our employees last week. So anybody who tested came back negative. So that was great news. I also wanted to mention our respiratory illness clinic. Today we had a meeting on that, and because of the, again, we're seeing less positive and less people that are coming to that symptomatic clinic. We're evaluating, can we move some of those resources back into our primary care MSC clinics? So that's good news. We'll still provide the service, but it's nice to know we may not need 2 providers there every day. So again, as we continue to see that the decrease in our region, currently we don't have any positive patients, COVID patients in our hospital. So always the question that's out there now is the vaccine. So I'll try to give you the best update I have. So just so you know, at Sierra College, we have done so far about 2,400 first doses. So just remember, we started that, I think, January 22nd. It's not open every day, but they have been very busy. I do want to mention that at our Eskridge conference room, we actually did a little over 300 first doses for our community there. So really, we've done about 2,700 first doses for our community. And I'm a very impressive team that is organizing that vaccine clinic. We've done about 650 second doses. So you're saying, well, where are the rest of the second doses? Well, that starts tomorrow with, over 650, and Monday, Tuesday, Wednesday, and Thursday are all second doses. So between those days, we'll be doing over 1,000 second doses. So they will be very busy up at the clinic. So currently, again, we are receiving vaccines from both Placer and Nevada County. Our primary focus right now is second doses. The reason for that is, I'm sure you saw in the news that there was delays in vaccines that being distributed because of the weather down in Texas. Somehow there's a throughput there. And so what the priority is catching up on the second doses. And that's actually in the state of California, that is the primary, with limited first doses that are coming through to the vaccine centers. So we are still, again, as I mentioned, the next 5 days are second doses. We have a limited amount of first doses. So one of the things that, so you're aware that does happen is we now report every Friday. I send a report to the state and they want to know how many first doses you have left. You can actually go on to the California COVID website. You can go by county, you can go by provider, and you can see how many doses they have on hand. So really our goal is to have as minimum as possible. When you do look on that, it does include first and second doses. So we did receive second doses for our teachers. So we actually have probably 1,000 doses on there, but we have to use those for the teachers in all of next week. So they do monitor that very clearly. So what are the next steps? So Harry did mention about Blue Shield, and we are still waiting to learn more about it. We do know that both Placer County and Nevada County have met with Blue Shield, and they have recommended Tahoe Forest Hospital as a vaccine site. In the state of California, eventually Blue Shield will be the distributor of all vaccines. And they will have contracts with all providers. And then we will receive, if we are chosen by Blue Shield to be a provider, we will actually at that point begin to receive our vaccines directly from Blue Shield. I can't tell you when that's going to happen, but we do anticipate that at some time in the future. So currently, any vaccines we do receive actually come from the county. One of the changes that will occur with that is in order to receive vaccines, you have to use the state's scheduling program called My Turn. And you may have heard about that or have read about that. So in order to qualify or in order to receive vaccines, again, we will begin to use My Turn if we're chosen. That is a self-scheduling program. Community member or resident will need to sign up for that. They will then be notified through My Turn when they are eligible. And when they are eligible, then they will be notified when there are appointments available. So for the eastern side, I don't know the mile radius. So if you get notification, if you're available, if there's vaccine at Tahoe Forest Hospital, if you'll actually also be notified on the west side. So more to come on that, but that is the process. We will move to My Turn once we have our knowledge that we will be a vaccine provider under Blue Shield and that we have an agreement, and we are waiting sort of for Placer County. We currently use a program called PrepMod for scheduling with Placer County, and probably will transition with them when they move to My Turn. Currently, Nevada County on the west side was one of the first counties to pilot My Turn. So they started it, I believe, last week, and have done a few appointments through My Turn. But again, it's a state initiative, and we are just waiting to see when all of that transition will occur. For Incline Village Community Hospital, I did want to mention, and they have done about 750 first doses. They'll do 100 next week again. So again, they continue to receive doses very routinely from Washoe County, 100 to 200 per week. In Washoe County, you actually sign up on their website, and it goes to the county, and then the county notifies Incline Village Community Hospital those individuals to reach out to. So that's been working very positively. I think only the other thing I just wanted to mention, which was presented by Ted and Lizzie in the very beginning, the tremendous outreach that has been occurring in collaboration with the counties to those that are more vulnerable in order to get the vaccine. And what they didn't mention regarding that presentation, not only did it include Nevada County residents and include Placer County residents, but we also reached out to the community in Incline Village and Crystal Bay. So it actually also included that community. So really, again, working with the counties and then our team who really has been, I think, very assertive in trying to reach out to that community. So I have to say, I listened to that presentation. I did not understand a word, but I have to tell you how proud I was to be part of this health system. It was incredible. It was so impressive. And the things that we have really done to reach out is second to none. And the counties were very appreciative of that communication. Are there any questions I can answer for you? Yes.
Judy, Dale here. For those who approach us in the grocery store line or on the ski hill and ask the question, when and how can I get my vaccination? I'm 40 years old or I'm 50 years old. Refer them to the hospital website or to the county website or to a statewide website, or what's the correct direction to send those people?
So I think the easiest thing for them to understand their eligibility today is to go onto the county website and see who they are vaccinating. So Placer County is vaccinating different than Nevada County. Currently, Tahoe Forest Hospital Vaccine Clinic has been given the initiative to vaccinate phase 1A, which is the healthcare, and then 65 and older. That is who we are vaccinating, and the education between K through 12. By the way, we do anticipate that to change in a week or so, but that's who we're vaccinating. And the nice thing about when my turn comes on, and hopefully we're anticipating in a week and a half, we are actually prepared to educate the community once we know that we will be using my turn. It's going to be on the website. We've already created that. It's going to go out in my chart and it'll go out in social media. That will solve a lot for the state of California because everyone will have to join my turn and they will let you know. It's a challenging process. I agree. Mm-hmm. Director King.
Yeah, I've got a question. If vaccine all of a sudden becomes very available, because they're doing lots of manufacturing, we have Johnson & Johnson, how much can we ramp up to increase the number of vaccines that we give?
Well, we do have a plan, and I will say under the leadership of Jason Grusidier, we have developed a plan to use the airport. And the airport is a drive-through vaccination. He has coordinated with a lot of resources in the town of Truckee and Placer County also to help support drive-through, where we estimate we could do 500 to 600 per day.
Okay, good.
I think that is, I can't tell you how many we're going to get. It would take us a week to implement that program, but there is a plan in place. It's all drawn out. Just depends on what Blue Shield chooses to do. I will say Blue Shield seems to really prefer high throughput. They are initially targeting those health systems that are in highly populated areas. So the Kaiser was their first organization they chose. Kaiser, 25%, by the way, 25% of the California population has Kaiser insurance.
Wow.
And then they're also going again to those high volume, high throughput areas. That's where they're trying to get people vaccinated. So we could potentially get that many. We'll just wait and see. But we do have something in place if we need to ramp up. Any other questions? Thank you.
Judy, thank you always for your updates. They keep us informed so that we can keep our friends and neighbors who ask us these questions better informed. So thank you again. We didn't pull anything from the consent calendar, so we'll move on to 18, board committee reports. I think we've had a couple board meetings.
Yep.
Okay, Michael,
Yeah.
Do you have, oops.
Yeah, I think Dale had his hand up as well, so, but I'm happy to go first. Two meetings to report out on quickly. One was the hospital foundation. The meeting this past month was really more of a working session, built on the January meeting where kind of year-end financials were presented. And Brett, overall, the chair of that group, really wanted to center the team on the understanding what's the purpose of the foundation, what are we trying to achieve, what are the goals we're setting. So very much a working session. I wouldn't say there's anything to report out on that, other than a lot of ideas were collected, and then we'll follow up next month on sort of aggregating that information. If I were to give my 2 cents, I would say there was a bias towards the role of the foundation to really fill in where the hospital can't deliver services due to reimbursement or other things. So mental health was one of the areas that was brought up where there's usually inadequate reimbursement. And also reaching out to some of the poor and vulnerable communities seemed to be a common thread for the foundation. The second meeting was the board quality meeting. Two items there worth reporting out on. One was a review of the quality assurance and performance improvement plan, which was agreed to or aligned and approved within that meeting. It was on our consent agenda tonight for approval. The second was Harry presented out on a white paper the framework for effective board governance and health system quality, and within that there was a quality assessment tool, and there were 4 areas that Harry had identified and shared out to the team for improved communication to the board. One was on the impact of quality on financials, so and probably more appropriately the impact of poor quality on financials. The second was on, well, second and third on actions around access and equality and equity for care. And the fourth was on communications around continuity of care for behavioral health. Harry or Janet, anything to add on the board quality, as both of you were present for that?
I think you did a nice summary on that.
Okay, thanks, Michael. If there aren't any questions for Michael on the quality or foundation, can we move on to Dale? Did you have a report?
Yes, your finance committee, consisting of Mary Brown and me, met with Crystal and her assistant Vicky, ostensibly to talk about accounts receivable. And I think Crystal summed it up by saying they're not out of the woods, but there appears to be a good trend line in improving that particular area of concern. Anything to add to that, Mary or Crystal?
No, I think that was certainly the dominant theme.
Okay, and that's the end of our committee reports. Does any of our board members have any other reports to give? Does anybody want to make a closing comment?
This is Jake. I'd like to, let me turn my camera back on. I was eating a salad and I didn't want you to have to see that.
In an X-Wing fighter, nonetheless.
In an X-Wing
That's
fighter.
impressive. Yeah.
Lettuce floating all over the place. I just want to say thank you. I didn't get a chance last time to the board for the, I don't know how to say it, panettone fruitcake that you guys got us for Christmas. I got to, my daughter, my youngest loved it.
I thought you were gonna say your dog loved it.
No, my daughter. But then I got to explain to them what fruitcake is.
You get confused.
Yeah, they didn't understand like fruitcake, so I got to explain to them what that was.
Oh.
So thank you for that. I appreciate it.
Oh, you're welcome.
Yeah.
Crystal? Unmute yourself.
You're muted.
Dale, you were asking about like a joint and if you would see all the charges. I actually was able to pull up a joint on the on our website. I didn't know if you guys actually wanted to take a peek at it or if you were comfortable with the presentation as it was. It's your option.
Does anybody want to see a joint?
I would love to see.
How do you think?
Okay.
Yeah.
So this is what it, if it's more than just one line, this is what it would look like. So this is a Medicare patient. I just picked Medicare, Part A deductible, and then it shows major hip or knee joint replacement or reattachment. It shows all the areas that would generate a charge and what the rev codes are. And then the total charge, $82,617. It does note there may be some items billed separately that we do not bill for. It shows you the self-pay, the minimum, the maximum, and then by plan, what they would reimburse. And then it does say for the Medicare coinsurance, plus any remainder of your deductible, $1,484. I didn't put any insurance information in, but you can see it does break out all the charges that make up a total hip replacement or a knee joint replacement. So it does provide that level of detail. If somebody wants to take this and go compare to Barton, they can.
Well, thank you, but I think I'm going to keep my own hips at that price.
Yeah, me too.
Yeah.
Well, thank you for pulling that up for us to see, something that we could really relate to. Any other closing comments? All right, then my closing comments is the meeting's adjourned, and we'll see you next month, if
All
not
right, good
sooner.
meeting.
Thank you.
Thanks.